Salam, I am Dr. Asad Sao. Now we approach the field of urology and men's health. It is essential to build a strong foundational knowledge of common scrotal pathologies. Among these, hydroceles and varicoceles represent two distinct yet frequently encountered conditions that every medical student must learn to differentiate and manage. A hydrocele is fundamentally a collection of peritoneal fluid within the tunica vaginalis, the membrane surrounding the testis. This accumulation results in a painless swelling of the scrotum. It is a condition that can affect males of all ages, from newborns, where it is often congenital, to older men, where it may develop for a variety of reasons. Understanding its origin is the first step toward proper diagnosis and care. In contrast, a varicocele involves the venous system of the scrotum, specifically the pampiniform plexus. This is essentially a network of small veins found within the male spermatic cord. A varicocele is the dilation or enlargement of these veins, much like varicose veins that can occur in the legs. This condition is far more common on the left side due to anatomical factors related to venous drainage. Unlike the often benign nature of a hydrocele, a varicocele can sometimes be associated with more significant clinical issues, such as testicular atrophy or impaired fertility, making its accurate identification and management particularly crucial for the patient's long-term health and well-being. The importance of distinguishing between these two conditions cannot be overstated. While both present as scrotal masses or swelling, their underlying pathophysiology, clinical implications, and treatment strategies are markedly different. A misdiagnosis could lead to unnecessary anxiety for a patient with a benign hydrocele, or conversely, a delay in necessary treatment for a varicocele that is impacting fertility. Therefore, a thorough understanding of their defining characteristics is not just an academic exercise. It is a critical component of competent clinical practice. This knowledge empowers future physicians to provide accurate information, reassurance, and effective care to their patients. This essay will serve as a comprehensive guide for medical students, breaking down these conditions in a clear and systematic way. We will explore their clinical features, from the subtle signs you might find during a physical exam to the classic symptoms reported by patients. We will then delve into the diagnostic tools that confirm your clinical suspicions, outline the spectrum of treatment options available for both conditions, and discuss the practical advice you can offer patients regarding precautions and lifestyle. By the end, you will have a solid framework for approaching these common urological presentations with confidence and precision in your future clinical rotations.
The clinical presentation of a hydrocele is typically straightforward and often characterized by its subtlety. The primary sign is a soft, non-tender swelling of the scrotum, which can be either unilateral or bilateral. Patients might describe it as a feeling of heaviness, or simply notice that one side appears larger than the other. A key feature is that the swelling is generally painless.
In infants, these are often communicating hydroceles, meaning they may fluctuate in size, appearing smaller in the morning and larger by the end of the day. This fluctuation is a classic historical clue. One of the most valuable techniques for diagnosing a hydrocele is transillumination. This involves shining a bright light through the swollen scrotum in a darkened room. If a hydrocele is present, the fluid-filled sac will cause the entire scrotum to glow with a reddish hue. This positive transillumination is a hallmark sign, as solid masses like tumors or hematocele will not transilluminate. You should also be able to palpate above the mass. In contrast, varicoceles have distinct characteristics. Patients may be entirely asymptomatic, discovered incidentally during routine exams or fertility workups. When symptoms occur, they manifest manifest as dull, aching, or dragging pain in the scrotum. This discomfort worsens after standing or physical exertion and is relieved when lying down. The sensation is described as a heavy feeling, particularly towards the end of the day. On examination, a varicocele feels like a bag of worms. This palpable, tortuous mass of veins is located superior and posterior to the testis and is more easily felt when standing. To enhance your exam, ask the patient to perform the Valsalva maneuver. This increases intra-abdominal pressure, impedes venous return, and makes the dilated veins more prominent. This maneuver is crucial for grading severity.
While a thorough history and physical examination are the cornerstones of diagnosing both hydroceles and varicoceles, imaging studies are often employed to confirm the diagnosis, rule out other pathologies, and assess severity. The primary diagnostic tool for both conditions is the scrotal ultrasound. This non-invasive, readily available imaging modality provides a clear and detailed view of the scrotal contents. For a suspected hydrocele, an ultrasound can definitively confirm the presence of an anechoic or black on the screen, fluid collection surrounding the testis, and can precisely measure its volume. It also serves the critical purpose of verifying that the underlying testis is normal, ruling out associated testicular tumors or inflammation. When a varicocele is suspected, a scrotal ultrasound with Doppler imaging becomes the gold standard for diagnosis. The Doppler component allows for the visualization and measurement of blood flow within the pampiniform plexus. This technology can detect the reversed flow of blood or reflux that occurs during a Valsalva maneuver, which is pathognomonic for a varicocele. The ultrasound can also measure the diameter of the dilated veins, typically defined as greater than 2 to 3 millimeters, which helps in grading the varicocele's severity. This objective measurement is invaluable, especially when the physical exam findings are equivocal or when assessing for potential impacts on fertility. In certain, less common scenarios, further diagnostic evaluation may be warranted. For instance, the sudden onset of a right-sided varicocele in an adult should raise suspicion for a potential retroperitoneal pathology, such as a renal tumor or other mass that could be compressing the gonadal vein. In such cases, an abdominal ultrasound or a CT scan of the abdomen and pelvis might be indicated to investigate the cause of the venous obstruction. Similarly, if a hydrocele in an adult appears complex on ultrasound, containing septations or debris, or if there is any ambiguity about the nature of the scrotal mass, further imaging or even surgical exploration might be considered to rule out a more serious underlying condition. It is also important to remember the context of the patient's overall health and presenting complaints. For a varicocele, particularly in the setting of a couple experiencing infertility, a semen analysis is a crucial diagnostic test. This analysis evaluates sperm count, motility, and morphology, providing direct evidence of whether the varicocele is impacting spermatogenesis. This information is vital for counseling the patient and making informed decisions about treatment. As the primary indication for varicocele repair in many adults is the correction of male factor infertility. Combining imaging with functional tests provides a complete clinical picture.
The management of a hydrocele is largely dependent on the patient's age, the size of the hydrocele, and whether it is causing any symptoms. In infants, the vast majority of congenital hydroceles are communicating and will resolve spontaneously within the first 1 to 2 years of life as the processus vaginalis closes on its own. Therefore, the standard approach is watchful waiting. and reassurance for the parents. In adults, asymptomatic, non-tense hydroceles can be managed conservatively with observation. No active treatment is necessary if the patient is untroubled by its presence. When a hydrocele becomes symptomatic, causing pain, a sensation of pressure, or significant cosmetic embarrassment, or if it is very large and tense,
intervention is warranted. The definitive treatment for a hydrocele is a surgical procedure known as a hydrocelectomy. This operation involves making a small incision in the scrotum or groin, draining the accumulated fluid, and then either excising the hydrocele sac or everting it and suturing it behind the testis. This helps prevent the reaccumulation of fluid. A less common alternative procedure is needle aspiration, but this is often discouraged as it has a very high recurrence rate and carries a small risk of introducing infection. For varicoceles, the decision to treat is guided by the presence of symptoms, evidence of testicular atrophy, or abnormal semen analysis in the context of infertility. For adolescents with a varicocele and documented ipsilateral testicular growth retardation, surgical repair is often recommended to preserve future testicular function. In adults, the most common reason for treatment is to improve fertility parameters in couples struggling to conceive. Pain is another key indication. If the characteristic dull ache is significant enough to impact the patient's quality of life and does not respond to conservative measures like scrotal support, then intervention should be considered. Surgical treatment for a varicocele, known as a varicocelectomy, aims to ligate or block the dilated veins of the pampiniform plexus, thereby interrupting the reflux of blood. Several techniques exist, including open surgical approaches, laparoscopic surgery, and a minimally invasive radiological procedure called percutaneous embolization. The microscopic subinguinal varicocelectomy is often considered the gold standard due to its high success rates and low rates of complications such as hydrocele formation or arterial injury. Percutaneous embolization involves a radiologist placing small coils or a sclerosing agent into the veins to block them off, offering a less invasive alternative for some patients.
When advising a patient diagnosed with a hydrocele, the primary message is often one of reassurance, especially for parents of infants with the condition. It is crucial to explain that most infantile hydroceles are harmless and resolve on their own. Parents should be advised to monitor the size of the swelling and to seek medical attention if it becomes suddenly larger, hard, or painful, as this could indicate a complication like an associated inguinal hernia. For adult patients with asymptomatic hydroceles, the main precaution is to be aware of any changes. They should be instructed to perform regular self-examinations and report any increase in size, new pain, or firmness of the underlying testis. For patients with a varicocele, particularly those managed conservatively, guidance focuses on symptom management and monitoring. Patients experiencing discomfort can be advised to wear supportive underwear or a scrotal support, which can help alleviate the dragging sensation by lifting the scrotum. They should also be counseled to avoid prolonged periods of standing or strenuous activities that they know exacerbate their pain. It is also important to educate them on the potential link between varicoceles and fertility, advising them to seek a follow-up evaluation if they and their partner have difficulty conceiving in the future. While there is no specific hydrocele diet, general dietary recommendations that promote overall health are always beneficial. For post-operative patients, a diet rich in fiber and adequate fluid intake can help prevent constipation, which is important as straining during bowel movements can increase pressure on the surgical site. Emphasizing foods like fruits, vegetables, and whole grains can support a smooth recovery. For varicoceles, some practitioners theorize that a diet rich in antioxidants and bioflavonoids may support venous health.
though strong clinical evidence is lacking. Foods like berries, citrus fruits, leafy greens, and nuts are rich in these compounds and contribute to a healthy anti-inflammatory diet. Ultimately, patient education is a key component of management for both conditions. It is essential to use clear, simple language to explain the diagnosis, the natural history of the condition, and the rationale behind the chosen management plan. Providing written materials or directing patients to reliable online resources can reinforce this information. Empowering patients with knowledge helps to reduce anxiety, improves adherence to follow-up plans, and ensures they know when to seek further medical help, making them active partners in their own healthcare journey.
In summary, hydroceles and varicoceles are two of the most common scrotal pathologies you will encounter in clinical practice. A hydrocele is a fluid collection presenting as a smooth, painless, transilluminating scrotal swelling. In contrast, a varicocele is a dilation of the pampiniform plexus veins, classically palpated as a bag of worms that increases with the Valsalva maneuver and does not transilluminate. Mastering the subtle but critical differences in their clinical presentation is the first and most important step toward an accurate differential diagnosis. These foundational skills of history-taking and physical examination will serve you well throughout your medical career. The diagnostic journey for both conditions is heavily reliant on scrotal ultrasound. For a hydrocele, it confirms the fluid and assesses the health of the enclosed testis. For a varicocele, Doppler ultrasound is indispensable for confirming reflux and measuring vein diameter, which is crucial for grading and making treatment decisions. Remember the red flag. A sudden, right-sided varicocele demands an investigation for retroperitoneal pathology. Always integrate your imaging findings with the complete clinical picture, including semen analysis when fertility is a concern, to formulate a comprehensive assessment and management plan for your patient. Treatment strategies diverge significantly. Hydroceles are often managed with watchful waiting, especially in infants. Surgical hydrocelectomy is reserved for symptomatic or very large cases in adults. Varicocele treatment, on the other hand, is indicated for pain, testicular atrophy, or infertility. The gold standard surgical approach is often the microscopic subinguinal varicocelectomy, though other options like embolization exist. Your role will be to understand these indications thoroughly so you can guide patients toward the most appropriate course of action based on their specific circumstances and goals. As future physicians, your ability to communicate effectively is as important as your clinical knowledge. You must be able to reassure an anxious parent about their infant's hydrocele, counsel a young man about the fertility implications of his varicocele, and clearly explain the risks and benefits of surgical intervention. Providing practical advice on symptomatic relief and lifestyle can significantly improve a patient's quality of life. By mastering the fundamentals of these two common conditions, from pathophysiology to patient education, you will be well equipped to provide excellent, compassionate care in the field of urology and beyond.